Thank you, Allison, and thank you for the opportunity to present to you some of the things we've been working on. I'll focus today, building on what Kurt has been talking about, um, on the issue of patient trust, and just provide some more data to dig deeper into this issue. Um, as was mentioned earlier, we know that patients change their behavior when they have concerns about the privacy of their health information, and or they perceive there's a threat to their health information, and this can clearly have a negative impact on the quality of data that is collected and that's used for secondary purposes or primary purposes for that matter. And I'll go through a number of examples just to illustrate. There's actually a lot of data on this. There have been a number of surveys of the US public, so these are adults, general adults, not specifically patients, and they indicate that between 15 and 17, actually Darren, can we move on to the next slide? Between 15 and 17% of US adults have changed their behavior to protect the privacy of their PHI, doing things such as going to another doctor, paying out of pocket when insured to avoid disclosure, not seeking care to avoid disclosure to an employer, giving inaccurate information or incomplete information on their medical history, self-treating or self-medicating rather than seeing a healthcare provider, or asking a doctor not to write down the health problem or record a less serious or embarrassing condition in the charts. Privacy concerns have also caused individuals to not be totally honest with their healthcare providers. So in addition to not seeking care, they may not be honest or lie in terms of the information they provide. In a survey of physicians in the US, nearly 87% reported that a patient had asked that information be kept out of their record, and nearly 78% of physicians said that they had withheld information from a patient's record due to privacy concerns that was expressed to them by the patients, or they felt themselves was necessary. In Canada, there have been similar results as well. Public opinion surveys in Canada found that when asked if over the prior year, Canadians have withheld information from their provider, 3 to 5% said yes because of privacy concerns, and 1 to 3% said had decided not to seek care for the same reason. Between 11 and 13% of Canadians have at some point withheld information from a healthcare provider because of concerns over who the information might be shared with or how it might be used. And with the highest regional percentage in Alberta at 20%. Similar results were reported by the Canadian Medical Association. Another study found that 735,000 Canadians decided not to see a healthcare provider because of concerns about the privacy of their information. And specific vulnerable populations have reported similar privacy concerns or privacy protective behavior, such as adolescents. And we see that with adolescents, when we do work with adolescents, they're very concerned about specifically their parents, what information they share with their parents, or that their parents can find out about them. People with HIV are at high risk for HIV, women undergoing genetic testing, mental health patients, and battered women. So a couple of things about this evidence. First, that these were done with the general public, so these were not necessarily with patients. When you compare these numbers to the numbers that Kurt had presented, which were focused on patients, you'll see a big difference. When you focus only on patients, the percentages are much higher, and in Canada it was around 40% or so. The other thing to note is this data that I just summarized is not specific to electronic medical records or patients whose physicians are using EMRs. This is just in general concerns about privacy leading to changes in behavior. Now, one other thing to keep in mind about patient trust is that actually, if you go to the next slide, this is a clear example. Was an article that appeared in the New York Times in January 2009. I put that there because I think it's a really illustrative example of patients self-treating, and this had to do with Dominican women living in the Washington Heights area of New York who were seeking abortions, but because of the stigma around that, they would go and get a drug in their local pharmacy which would induce abortions, and sometimes it didn't work very well. and as you can imagine, the horrors that would occur with this. And the primary driver here, of course, was privacy, or concern about what their community would know, would say, and the stigmatization around this, if this became general knowledge. This is a good example of self-treatment because of privacy concerns. The other thing about patient trust, if we go to the next slide, is the issue of asymmetry. So there's also a lot of evidence that trust is hard to gain, but it's easy to lose. Once patients start losing trust or have started having concerns around how their health information is being used, this would be hard to regain afterwards. And I think this is a very important point to keep in mind, is that the Canadians trust their healthcare providers, trust the system in general to manage their data well, and we really cannot afford to do things that will erode that trust, because it may be hard to build it up later on. And there's this asymmetry is pretty well established in other areas, for example, in around the genetically modified foods and around the use of nuclear energy, where there's been an erosion of trust. So the number of reasons for this. One is that negative events or news carry more weight than positive ones, so this is called the negativity bias. Negative news is perceived to be more diagnostic, so if people hear bad news or negative news about a product or a service, it carries more weight than positive news or positive information. People tend to want to avoid loss, so they weight negative information more greatly. So this is a well-established behavioral economics type behavior of individuals, kind of the loss aversion. And sources of negative information appear more credible than sources of positive information, because sources of positive information are perceived to be biased. People also interpret information according to their prior beliefs. So if someone has a particular view and they see information supporting that view, it reinforces it. If they see information that is opposing to that view, it will have less of an impact on them. Undecided individuals tend to be affected more by negative information, and people with positive prior beliefs may feel betrayed by negative information events. So people who trust the system and they start hearing stories and experiencing breaches that affect them personally, the strong sense of betrayal leads to a rapid loss of trust. And I think it's important to keep in mind that this is not theoretical stuff. We did a series of focus groups with healthcare providers. So these were family doctors from across the country. This was in 2009, and we had about 40 physicians participating in those focus groups. And we're talking about data sharing for public health purposes, and one of the issues that came up was that the stories that they hear in the news about breaches of health information was an important factor in their reluctance to share information or to allow the sharing of their patients' health information. So it's affecting the physicians' perceptions as well of how health information is managed. So they feel that if they give information out to somebody else, in this case it was public health, because of the stories they hear, they're concerned that public health will lose their data because there's so many breaches happening. It's all over the news every day. So this is an example of erosion of trust, I think, a clear one. So the issue now is when does this happen? So I'll talk about the insider, let's call them insider breaches, from a primary and a secondary perspective, when health information is used and disclosed for primary purposes and for secondary purposes. Just to give you a concrete example, or a set of concrete examples around this. The problem is when a large number of people have access to medical records, whether it's for primary purposes or secondary purposes, we trust the people who give the data to. The vast majority of them behave very well and act in a very responsible way, but some don't. And it's those some that don't that cause this problem. or this erosion in privacy. So in the context of primary uses of data, um, we talk about peeping or snooping, and it was discussed a little bit by Kurt in the previous segment. Um, so I'll just go through a few examples of peeping or snooping. Peter Swires, there's a nice article about this, and he outlines three types of peeping: the gaze, the gossip, and the grab. The gaze is the act of looking at something that is restricted, like the health record of a patient, to which someone should not have access. So this by itself violates an individual's privacy. The gossip inflicts additional harm to the individual by affecting their reputation and could lead to harm such as denial of insurance, loss of employment, or social stigma. And then the grab is when the peeping is done for financial gain. For example, a good example of that is and it was well publicized, is the Lawanda Jackson case. She was an administrative specialist at the UCLA Medical Center, and from 2006 until she was convicted in 2008, the National Enquirer was paying her to provide them with medical information about celebrities such as Britney Spears, Farrah Fawcett, and Maria Shriver, who were admitted to the hospital. She faced up to 10 years in prison and was fined $250,000. Peeping on celebrities is very common, unfortunately, despite warnings, and I'll talk a little bit about that as well, despite the fact that the employees may know the consequences, it's for some reason they still feel compelled to do it. And it's not just celebrities, as in actors and so on. You see it with politicians, well, sports figures as well. There's other cases with the George Clooney after he suffered a motorcycle accident. Up to 40 healthcare workers at the Palisades Medical Center were suspended for inappropriately accessing or leaking confidential information about him and his girlfriend. In UCLA as well, Medical Center, 127 healthcare workers were caught accessing medical records without authorization this is a little bit dated, but between 2004 and 2006. Another example, Kaiser Permanente, 2009, with Nadia Suleiman, the famous mother who had gave birth to octuplets, and her records were accessed by, an investigation found that eight healthcare workers at other facilities not related to her care were accessing her records, and the Kaiser was fined $250,000 by the Department of Public Health. More examples. In 2010, 6 California hospitals were fined for security breaches related to unauthorized access to medical records. Pacific Hospital of Long Beach was fined $225,000 for an employee who accessed 9 records. Children's Hospital of Orange County, $25,000 fine. Kern Medical Center was fined twice for a total of $310,000 for multiple breaches. $60,000 fine was issued to Delano Regional Medical Center, and so on. You get the picture. In Canada, we see similar things. There was a case in Calgary, the clerk in Calgary who was fined for inappropriately accessing medical records of the spouse of the man with whom she was having an affair. So lots of love triangles in the Canadian stories. The patient was diagnosed with cancer at the time her record was accessed several times by her husband's mistress, who was working in the office of a plastic surgeon, and the mistress was fined $10,000 for that behavior. There's another employee of Capital District Health Authority in Nova Scotia who was inappropriately viewed medical records of family members and friends between 2005 and 2011. They flagged 15 cases of unauthorized access. And then if you go through the orders of the various privacy commissioners, the Ottawa Hospital had 2 orders against it in Ontario. Both of them were love triangle cases. The first case was a nurse who was the girlfriend of her estranged husband, of a patient's estranged husband, and the nurse worked at the hospital. And even though the nurse did not provide care to the patient during her stay, it later turned out that she was looking at the medical record of that patient and providing the information back to her husband. Another Ottawa Hospital case, patient claimed that diagnostic imaging technologists at the hospital had accessed her medical records without authorization on 6 separate occasions. Technologist was the ex-wife of the patient's current spouse. You get the picture. Um, the other provinces as well, the really interesting ones in Alberta. Now, in Alberta and BC, you have province-wide systems where a very large number of healthcare providers access data, and it's not just within a single facility. We're talking about um, province-wide access. Um, so, in one example, a record of a patient had been accessed by 9 physicians through Alberta Netcare, and they were not her physician. Um, and it turns out that this patient suspected that his ex-wife, who was a nurse, and her partner, who was a doctor, may be responsible, although their names did not appear in the audit trails. And it turns out later on, after an investigation, that uh, the uh, um, the doctor was using a colleague's account to access the records of the patient. So he would find accounts that were opened, go in and access those records. Various other stories with the pharmacists also using their access to the province-wide prescription record data and peeping and snooping on people they know, and the information leaking. So we know that this happens in Canada as well. Most of these cases are detected by complaint. Someone suspects that their information has leaked and they file a complaint with the regulator, and the regulator investigates, and they reveal this essentially breach. Now, in the context of secondary uses of information, similar situations arise because large databases are shared with individuals as well. They may be researchers or public health professionals, or maybe commercial actors, and there's a possibility, what we call spontaneous identification, where someone looking at a database will recognize their neighbor, their relative, their coworker, or somebody else that they know, or a famous person for that matter. And we've actually had cases like that where researchers that I know of did recognize records when data was used for secondary purposes. And although these things are generally not they don't get to the media, they're not reported on as much. It's a very plausible situation, and as data is used for secondary purposes more and more, as the situation increases, you're going to have more examples or situations of the spontaneous recognition or identification of individuals in databases that are shared. And of course, there's also the possibility of more active re-identification attacks on the data. So just to illustrate how this could happen in the context of secondary uses, you'll see a graph here, and this is a very simple example just to illustrate how innocuous information that seems non-identifying can be quite revealing. So in this particular graph, the x-axis shows the number of characters in the postal code, and the y-axis shows how unique individuals are in the population. And in the next chart, we see that when you combine the full date of birth and the full 6-character postal code of Canadians, the approximately 98%, well, 96 to 98% of the population is unique. Can you move the graph, the slide one up, please? So that about 96 to 98% of the population are unique in just those two pieces of information. So the problem there is if you have a database that's being disclosed for secondary purposes, if someone recognizes the postal code and the date of birth of someone in that database, they're almost certain that they have the correct identity. If you add gender, it's higher. It's at about 99%. And if you only look at adults, it's almost 100%. In the next graph, we see just another example of the year of birth instead of the full date of birth, and uniqueness goes down. So if you have the 6-character postal code and just the year of birth, about 70% or so of Canadians are unique. Still a high percentage, but reducing the precision or the amount of detail in the data, of course, does result in a reduction of uniqueness, makes it a little bit harder to identify individuals. And on the next slide, we have a graph showing longitudinal data where there's information on residence trails, or where people live over a 3-year period. And as you can see, uniqueness increases when you have longitudinal data on individuals. I think that's on the next slide. Yeah, as you can see there, 6-character postal code, year of birth over 3 years, about 85% or so of the population are unique. So the key point there is that even when databases are disclosed for secondary purposes without any name or address information, it's still possible to identify individuals because even very simple demographics are quite revealing, and they make individuals unique within the population, so people can be re-identified quite easily. Okay, so in the next slide then I'll talk a little bit about mitigation, or things you can do to manage those risks. From a primary uses perspective, you have passive and active analysis of audit trails. Passive analysis is what a lot of organizations will do, is they will collect audit trails but not do any proactive analysis of those audit trails, and then they'll respond to complaints. We don't really know in general, without any, when there's no enforcement, what the rate of peeping is, so it's not possible to say whether passive is good enough or not. But essentially, someone suspects that their information has been viewed by someone else who is not authorized, either because a lawyer in a divorce case for the other party reveals medical information about them, or, as happened in some cases, people at the church start talking about your medical condition. Then the patients would ask for an investigation, and then the steward or the regulator would initiate one. More active audit trails is when the data is analyzed on a proactive, audit trails are analyzed on a proactive basis to identify patterns or generate alerts before the patient realizes. The patient might not even realize that it's happening yet, but the audit trails would generate, or the analysis of the audit trails would generate red flags around this. And there are a number of products that can be used to collect these audit trails and to analyze them. Then you have the Lockbox as another option, which is an option that's available to patients to hide or conceal certain parts of their record if they suspect somebody who is potentially peeping at their records, or want to ensure that they don't peep at their records. Then they can proactively go and request that their record be locked from those individuals, and they have this right in many jurisdictions in Canada. In terms of the system's ability to implement Lockbox, it varies quite a bit. It depends on the extent to which it's a legacy system, and whether it's an optional lock, or like a VIP flag, for example, or it's a hard lock, also will vary with the system that's implemented. And then for secondary uses, there are de-identification methods, and this is something that we have worked quite a lot on. And if you go to the next slide, you'll find more information about our lab, and we have a mailing list which disseminates information on a regular basis about activities related to de-identification and data protection. Also consent and ethics issues around data sharing for health information. I would encourage you to subscribe. Go to the website and subscribe to this mailing list, and you get more information about this kind of work that I've been talking about in this presentation. And with that, I'll leave it, and then I think we'll open it to questions. Thank you.